Finally, coordinating care. This just looks at the dollars. Dollars are not all that's important here. Identified early on, acknowledged that the programs that support this population, that is Medicare and Medicaid, do not cooperate, do not coordinate, and we break an individual into their component parts and treat them separately. So effectively coordinating care for a heavily dual eligible population, more than 85% are in both programs, is going to require ultimately addressing the Medicare HALO services. We don't know how soon we'll be able to get to this policy objective because it requires coordination with Medicare. And across the country, that coordination between Medicare and Medicaid has been coming very slowly. Those mechanisms are only now developing, and I think a lot of folks on Capitol Hill are hearing from some providers, let's not go too quickly here, let's not coordinate too quickly. I'm of a mind that these dual eligibles are among the least well-served individuals in society because of that lack of coordination, and that we could hardly do worse than we are today as a country in addressing the needs of dual eligibles. Here are how the dollars work out. We don't actually have the Medicare data for Arkansas yet, so we're just trying to give an order of magnitude here for the Medicare HALO spend. But you see the Medicaid long-term service and support core spend. This is an average of cost, both the community-based individuals and the nursing facilities, about $38,000 a year. The Medicaid HALO cost, which is essentially the wraparound or supplement to Medicare, is about $6,000. So our Medicaid average cost for the whole person is about $44,000 a year. We don't yet have the HALO spend for our Medicaid recipients in Medicare, but nationally it's, we would probably put it in the $13,000 to $23,000 per year range, and you want to compare that to the $6,000 that we pay for HALO, and you see there the Medicare is primary payer for the vast majority, and we're secondary payer. We're just wrapping around, and that gives a total of anywhere from $57,000 to $67,000. I think it indicates that the challenge of coordinating care for these individuals is shouldn't just be Arkansas's responsibility. We should have seen years ago that the federal government and CMS and the Medicare program actually cared about this population. They haven't shown that yet. I'll just say it flat out. They'll have shown it when they allow states to easily and successfully implement programs, share savings with the Medicare program. They haven't done that yet, although they're making progress. I think it indicates that the dollars we've been talking about for this conversation so far are still the majority of the spend. So for this population, the biggest dollars are the Medicaid dollars spent on long-term services. Medicaid is a majority of the spend for this population. But unless we can draw on that the Medicare HALO spend, we won't quite be getting a full bite at the apple. Here's just a sense of the time frames and the pace at which the DHS and the Payment Improvement Initiative are addressing long-term service and supports. What are we doing right now? The episode and the health home model development. Elements for the episode and health homes need to be defined. We talked a little about that. Quality metrics, provider requirements and payment mechanics need to be designed. That's ongoing, and we're not close to being finished with that at all. Feedback gathered, that's what we're doing now. Educational work groups and town halls eventually to answer questions. We'll get there once we have information and a plan to share, which again is a ways down the road. We have not launched the use of the universal assessment of need for those in an institution. We don't currently have a plan for that. So determining the role of assessment in eligibility and payment for the institutional residents is ongoing, but I would say we're still at the early stages, and that's not the topic today, but it will be in the future. We haven't assigned responsibility for carrying out any universal assessment for the institutional population. The reporting period to data collection for the long-term services and support payment reforms, or episode, we're kind of classifying this as an episode. That's not really all that important. The payment reforms and the health home, really the second half of next calendar year is what we're targeting. A lot has to happen between now and then for that to occur, but that is the target. Feedback period, when formal and informal response would be invited, would be in the fourth quarter of 2013. Refinements to the version 1.0 assessment and payment mechanisms. For those of you who haven't kind of been on the inside as we've developed medical episodes, this is an iterative process. We're developing a measure, we're implementing a measure, we're developing payment methodologies that use that new measure, new payment methodology, new measure. It usually takes us several cycles of feedback with stakeholders to get it right, and we always build in a period of testing, really, when everybody sees the numbers, sees how it would work for them, etc. And in that period, we still have time for improvement. So that's the feedback period. And we're looking at episodic payment beginning early 2014, so a little, really more than a year from now. Performance-related health home payments, that's the coordination of care in that quarter as well. So roughly speaking, we're looking to try to make these decisions and begin implementing, et cetera, so that we can actually change the way we pay beginning as early as the first part of calendar year 2014. A lot has to happen between now and then for that to occur, and I mean to imply that for both community-based services and for institutional care. Let me pause there. Connie, come up and tell us where we are on the HCBS assessment.
Aging and Adult Services has been working this past year with the vendor on the software MedCompass to develop the universal assessment, which we are calling R-PATH. And the R is A-R, my southern accent, it may sound like I'm saying O-U-R, but it's A-R, PATH. It's going to provide an electronic process for completion of the functional assessment of individuals applying for home and community-based services. CMS approved the new assessment tool through the waiver amendments that we made, and recently, as some of you are aware, Medicaid policy was promulgated to replace the 703 for home and community-based services with this new assessment tool. And we are encouraging all home and community-based providers to review the revised Medicaid manuals on the Medicaid website. During November and December, we're still finishing up some training, but during this time period, all the nurses, the Aging and Adult Services nurses, were trained on using this software, and it represents a major change in how the nurses will conduct assessments and develop plans of care. And they're going to be using laptops that are preloaded with the software, so they'll go into the home to conduct their assessment with their laptop using the assessment tool. We are on track to begin using the new assessment tool January 1, since that's a holiday, technically it'd be January 2nd. New clients coming in to applying for home and community-based services will be assessed with this tool. And existing clients, we're going to assess them at reassessment. And so that'll be staggered across the year because all of the clients are assessed or reassessed on an annual basis, and sooner than that if there's a change in their condition. The change should not affect how providers provide services. We are asking providers to continue monitoring the plans of care that you have, and if you see that one is coming up for an expiration, to contact the DAASRN so that we can get out there and take care of that.
All right, that's the presentation. Our goals today were primarily to share the data we have with you. So I'll just confirm there isn't some additional analysis that's insightful at all that we haven't shared. So as of today, as of right now, you have what I have. There's nothing else out there that's driving our thought process or development that you're not looking at. So we wanted to hear whether you had comments on that data, what suggestions you had for the next level of analysis. We've talked a little about policy direction. That wasn't necessarily the goal today. I'm just trying to be as transparent as I can with the thinking and to keep you apprised and kind of think ahead. But certainly take comments about that, but mainly data today. So
I'm assuming that whatever entity does the assessments for long-term care, regardless of whether it's community-based or institutional care, that will be the same entity and that it will be an outside entity for both groups.
So that is not obvious. Let me go back to this chart. We don't know the answer to that, so I appreciate your comment. So again, this was a little bit of a surprise to us. So again, thinking about the path and the process for assessing an individual's level of need, 85% of individuals are really in a nursing home in very short order. 15% come through the community in a way that you might describe as parallel or the same as the HCBS applicant. And just as we've begun to think through the mechanics and the practicality of, the biggest number on the page is the acute hospital. What does it mean to administer a universal assessment of need to an individual that's in an acute setting? What's the turnaround time? What's the setting? Who can do that? Who can get to the hospital? The other issue is that the DAAS is administering the HCBS universal assessment. I think some of you may know Director Seelig and I confirmed that we would not be asking for additional staff. Did that yesterday to the Budget Committee. The context was for Medicaid expansion, doesn't really matter. We're not asking for additional staff. So the next question, so there's a resource issue there. Then the third question, which we do not have an answer for, which is fundamental, how many of the nursing home residents will be administered a universal assessment on the way in? Ideally, all, so that we have a common assessment of need on the way into care. But again, that's we have over 10,000 individuals in the nursing home at any given time. Close to 15,000 over the course of a year. It's a tremendous number of universal assessments to administer, and DAS clearly doesn't have that capacity right now. So I've just described to you the current state of the world and what we know, and that we haven't, just to confirm, we haven't made decisions about that. But it is also not obvious to us, inviting comment now, it's not obvious to us that the same group would do both the community-based instrument, the community-based assessments and those assessments for individuals that are in the inpatient setting or other institutions. That's, again, we're looking for. Now, having said that, if they were different, we have to make sure that they end up with the same result. And we would predict that if we didn't do a great deal of oversight, if those were different groups, very likely we would end up with, ratings that differed, by who was doing them. It takes a great deal of effort. This is always true when you administer surveys or assessments, etc. You actually, unless you try and have a system in place to assure consistency, you probably won't have consistency. That's a problem if we're going to be attaching payment to level of need. To appropriately reimburse for the level of need and the specialty, either in the community or in the institutional setting, we need to come up with the same results. So we have a little bit of an operational challenge as well as a fundamental question. We were on a phone call with several states this week, listening to how other states do this. Is it fair to say, those of you on the phone call, it's typically not the same group, or does it vary? It's all over the map. I mean, in some states, it's the hospital discharge planner that does the acute care.
Well,
assessment.
I guess my follow-up question would be, is it safe to assume that someone other than the provider of service would do both assessments?
So we remain committed, and that's a commitment that the department has made, and that we're getting back to kind of first principles of universal assessment across, or payment improvement across areas, developmental disabilities, etc. Some measure of independence is our goal. We have a practical challenge, which is all of those MDSs that are administered every year for each resident. That's a whole ton of work. It's a whole ton of work. So, and it's going to have to be done anyway. And the question is, do we come in and try to replicate that? That's a lot of work. That's a huge operational challenge. Isn't necessarily shared across all of our payment improvement areas. So, again, inviting comment. Those are our concerns.
Discrepancy also between home and community-based.
Right.
Okay.
So my principle would be that we have to have a mechanism to assure consistency across settings in the administration of a universal assessment. That may not mean and does not necessarily imply that it is the same people doing it in every single setting. There's more than one way to skin the consistency cat.